When a patient is critically ill, things can change in a heartbeat, literally. But have you ever wondered how doctors can see what's happening inside the cardiovascular system in real time? Well, today we're diving into the incredible science of hemodynamic monitoring. Let's get right into it. So picture this. You're in an ICU. A patient's condition is unstable, and every second counts. How do the clinicians get a constant, accurate, moment-to-moment picture of what that patient's heart is actually doing? It's a massive challenge, but the solution is pretty fascinating. It all comes down to something called hemodynamic monitoring. This is where technology and physiology meet, giving the medical team a set of powerful tools to essentially read the language of the heart. And that language is spoken in terms of pressure, flow, and oxygen. Okay, so here's the official textbook definition. It sounds a little dry, I know, but what it really means is getting the raw data, the numbers, that tell the full story of what's going on inside a person's circulatory system. And believe me, this data is absolutely essential for making those critical, life-saving decisions. But before we get to all the cool gadgets and the high-tech tools, we've got to learn the language they're speaking. So what are these key numbers, these core metrics, that tell us so much about how the heart is performing? The big one, the master metric of it all, is cardiac output, or CO for short. You can think of this as the ultimate summary of the heart's performance. It's simply the total amount of blood the heart manages to pump through the entire body every single minute. It's a huge deal. So how do we figure that out? Well, it's actually a really simple but powerful formula. Cardiac output is just your heart rate, beats per minute, multiplied by something called stroke volume, which of course begs the question, what's stroke volume? Stroke volume is where we start to zoom in. If cardiac output is the total volume per minute, stroke volume is the amount of blood that gets pushed out with every single individual heartbeat. So you see, to really understand that big picture number, we have to understand this smaller, more specific one. And if we want to understand stroke volume, we've got to peel back another layer of the onion. It's determined by three main things: preload, which is about how much the heart fills up; afterload, which is the resistance it has to pump against; and contractility, which is just the raw pumping strength of the heart muscle. Let's break down those first two. First up, preload. This is all about the stretch, specifically how much the heart muscle stretches right before it squeezes. The balloon analogy here is just perfect. The more air you blow into a balloon, the more it stretches before you let it go, right? It's the same with the heart. The preload is the stretch caused by the blood filling up the ventricle. And then there's afterload. So if preload is about filling the pump, afterload is all about what happens when the pump tries to push the blood out. It's the resistance the heart has to fight against. And the garden hose analogy is a great way to picture it. If you put a narrow nozzle on the end, it creates a ton of resistance, making it way harder to spray the water. That's exactly what high afterload is like for the heart. Okay, so now we know the language. We've got cardiac output, preload, afterload. So let's look at the actual tools of the trade. This is the monitoring toolkit, the high-tech gauges clinicians use to peer inside the cardiovascular system. So how do we actually measure all this stuff? Well, we're going to focus on three key invasive tools, and by invasive, we mean they're actually placed inside the body. You'll find these in just about any ICU: the arterial line, the central venous catheter, and the pulmonary artery catheter. Each one gives us a unique piece of the puzzle. Let's kick things off with the most common one, the arterial line, or as you'll hear people call it, an ART line. This little device is the frontline tool for getting a continuous, beat-by-beat, live stream of a patient's blood pressure. Now, an ART line isn't like your typical blood pressure cuff that gives you a reading every few minutes. No, this gives a constant waveform, which lets us calculate something called the mean arterial pressure, or MAP. The goal is to keep that MAP in a specific sweet spot, usually between 70 and 105, to make sure all the vital organs like the brain and kidneys are getting enough blood flow. The ART line is fantastic for seeing pressure in the arteries, but sometimes you need to know what's happening right inside the heart itself. And to get that information, you've got to go deeper. That's where central and pulmonary catheters come in. So a central venous catheter gives us a really important number called the central venous pressure, or CVP. This is a direct measurement of the pressure on the right side of the heart, and it's our best way to estimate the right-sided preload we talked about earlier. As you can see, the normal range is super low, just 2 to 8 millimeters of mercury. Okay, so let's apply this. We know normal CVP is between 2 and 8. So if you're looking at a monitor and you see a patient's CVP is up at 10, what story is that number telling you? What could be going on with their heart or their fluid levels? Well, a high CVP is basically a big red flag that one of two things is probably happening. Either the patient has way too much fluid in their system, we call that volume overload, or the right side of their heart is starting to fail and it just can't pump out the blood that's coming back to it. See how that one number can totally guide what you do next? It's incredible. Okay, so this central venous catheter we just talked about is perfect for understanding the right side of the heart. But what about the left side? For that, clinicians need to bring out the more advanced tool, the pulmonary artery catheter, or PA catheter. And as you can see, it's a bit more invasive, but it gives us an invaluable look at those left-sided heart pressures. And the star of the show for a PA catheter is a metric called the pulmonary artery wedge pressure, or PAWP. This is our best estimate for the preload on the left side of the heart. And just like CVP, it has a normal range that everyone watches like a hawk, usually somewhere between 6 and 12. And why is this number so important? Well, as the saying goes, the PAWP is a really reliable indicator of how well the left ventricle is working. For patients who are incredibly sick with conditions like severe heart failure, this number is an absolute game changer. So we've thrown a lot of acronyms and tools at you: CVP, MAP, PAWP. But let's take a step back and ask the big question. Why does any of this matter? Let's connect all the dots and see how this data gets turned into actual patient care. It all comes together in this beautiful clinical feedback loop. First, clinicians use these numbers to assess how the heart is doing. Then, that data tells them what to do. Does the patient need more fluids, or maybe a drug to help the heart pump stronger? After they give the treatment, they keep watching the numbers to see if it's actually working. And all of this continuous monitoring lets them spot problems early, often before they turn into a full-blown crisis. So, we'll leave you with this thought. The next time you're watching a medical show and you see all those numbers flashing on the bedside monitor, you'll know they're not just random digits. They're telling a dynamic, second-by-second story about what's happening deep inside the heart, a story that you now know how to read.